Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. Thank you for joining me in another demonstration video of our soon to be launched WAXscope. We have here a patient who attended with bilateral fully occluding keratin, so dead skin filled with keratin, which is a protein also found on our hair strands and fingertips, our fingernails. And this blockage is extending right from the entrance to their eardrum. I've had quite a few of these cases of late, full of dead skin keratin as opposed to earwax. And the thing that they have all in common, the recent cases at least, where the patients were a bit older and they all wear hearing aids. So of course hearing aids help you hear, but they can also help hinder the natural migration of dead skin out of the ear. So our ear canals and the outer layer of the eardrum, which is three layers thick, is lined with skin, the epidermis layer, and as that skin dies and is replaced by another layer of skin underneath, it's pushed forwards and it begins to shed and migrate. And dead skin in the ear migrates sideways, it should do, out of the ear, like a conveyor belt. And any wax sitting on the surface of the dead skin, this conveyor belt is naturally transported out of the ear. As we get older, the skin becomes a lot drier because our skin cells are less able to moisturize themselves and retain internal intracellular fluid. Also, the glands, the sebaceous and ceremonous glands, are less active. They receive less blood supply as we get older, so they don't produce as natural oils and sweats which help to moisturize the canal and the skin. And of course, when you insert a hearing aid, you're stopping that natural migration of skin. Here at the bottom, it's really lodged, so there's a slight narrowing of the ear canal. You may see that, and there's also a bit of a dip, and this wax plug behind that narrowing is larger. So we're having to try to bring this through, which is difficult. And in addition, as I mentioned at the beginning, the skin is strongly adhered to the canal wall. So what I'm trying to do is prise this away. You can see there, I'm trying to go to the back portion of the canal wall, glide the hook in between the keratin plug and the canal, and I'm trying to just lift it up and away. The consistency of this keratin plug is quite dry and crumbly, so the hook is breaking it up into little pieces, which I can then either continue to extract using the hook, or I can revert to the suction probe, the vacuum, to suction away these little shards of dead skin and fragments that are breaking away. I'm using the 4.25 millimeter internal specula here to help dilate the ear canal. We have a smaller size, a 3.5, and two larger sizes, a 5mm and a 5.75. And with the suction, you see I've got a good suction grip here, and I'm slowly trying to bring this forwards, almost trying to bring this over a little ridge on the base of the ear canal, and it just wasn't powerful enough to do that. I think now I'm going to use, let's see, is it going back to the ear hook again? I just want to separate this a little bit more. I'm exerting quite a lot of force here, and it's still quite difficult to chisel away. I'm just going to go to the roof. I'm going to glide the ear hook in. So the right ear hook, which is the name given to this ear hook that I've developed, not only is it angled, it's a 30-degree bend, so it makes insertion a lot easier, and it also helps maneuverability. But the tip of this hook is a lot more tapered and narrowed than the traditional St. Bart's ear hook that I was using before, which is a bit more blunt. And it's very useful in cases such as this because it can help almost dissect and break this keratin plug into smaller pieces. It can penetrate. So although it's not removing large chunks, it is chiseling it away, breaking it into little pieces, which will then assist in the removal moving forwards. So I managed to prise a little bit out here. But the amount of force I was having to apply to do that just goes to show how impacted and solidified this keratin plug is. So I've probably got a third of this out, so there's still quite a lot left. If you wait till the end, there is a still image, you can see just how much we removed. Once more, I'm going to the base, I'm trying to lift this up, It's slowly separating, but I suspect this plug, close as it extends towards the eardrum, is still attached to the canal wall. So although I've managed to separate it in this section, this plug obviously doesn't end here. It extends immediately towards the eardrum, and it's most likely still adhered to the canal wall there. And when the plug is adhered and attached to the canal, it's a tug of war. The canal doesn't want to let go of it, and it's up to us to kind of separate. So you can see I'm working all the way around the edge. You've got this fresher layer of dead skin that's lining the periphery of this plug. So if you can separate that, actually it helps you to remove the main plug, because it's that outer layer which is, it's almost acting like double-sided sticky tape. It's attached to the keratin plug, but it's still also attached to the canal wall. So this is a large piece that's broken up. So it's now just a matter of trying to bring this out of the ear. But the surface of this keratin is quite solid, and so it's difficult to get a suction grip. The sucker is gliding off it because it's so smooth and flat and hardened. So again, I'm using the hook. I'm going towards the front portion of the ear canal. So previously we were working at the back. This is the opposite side of the canal. And I'm just going inwards with this. I'm trying to separate it. And then there's just a little piece just near the entrance. I'm going to try go underneath it and lift up. So you can see with the WAXscope, the view you get, it's a very magnified view, detailed view. But of course, the WAXscope is a lot more narrowed. It's not an endoscope. So with an endoscope, the lens is inside the ear, hence the term endoscope. And you can't compete really with the view provided by an endoscope. But as I've mentioned earlier and in previous videos, an endoscope is a difficult instrument for many people to use. It does require high skill level. So an endoscope, therefore, is no good to someone who's not able to use it. So hence why I've developed the WAXscope. So it's more user-friendly, and the view, I would say, is far superior to any head-worn microscope. I've had some ENT report that it's they're very happy with the view, and they'll put it on par with an ENT microscope, and for wax removal probably slightly better. But the depth perception is acquired differently compared to an ENT microscope, which uses binocular vision. So what do I mean by binocular vision? Binocular vision is when you're using both eyes to visualize an object, and that then gives you depth perception. And you can actually test this yourself. If you put one hand in front of you and raise a finger, and then with your opposite hand use one finger to touch the tip of the other finger, you're able to judge that quite well. But if you then close one of your eyes, you'll see it's not as straightforward. So when your brain receives the image from both eyes, it enables it to judge the depth a lot better. So with an ENT microscope, what it does, it converges artificially your interpupillary distance. So essentially it brings your eyes together closer, I think to about 12 centimeters, or is that, I think it is 12 centimeters or thereabouts. And most of our interpupillary distance is a bit greater than that. And by bringing it together, it gives you a better chance of visualizing wax in the ear from both ears. If your eyes are really, really wide apart and you're looking inside someone's ear, but it's impossible because the ear canal's so narrow to see the wax with both eyes. So instead, your eye's just receiving the view from your brain receiving the view from one eye, and you get monocular vision. And a lot of people actually struggle to develop the binocular vision, because at first you almost see double vision. You're seeing both sides from both eyes, and they're not converged, and you have to train your brain to converge these images you're receiving from both eyes into one single image. And so it does take a bit of practice. Even with an ENT microscope though, if you've got very deep wax and a very narrow ear canal, it's still not possible to see that, even with the artificial converging of the pupils. So most head-worn microscopes, apart from one on the market, don't have that converged pupillary review. Instead, you are just using your own natural distance between, spacing between both eyes to view that wax in the ear. And, quite often, because the ear canal is so narrow, you're not able to see the wax with both eyes. So you're getting monocular vision. Now, with the endoscope, that again, it's monocular vision. You're looking at a 2D screen, although you can get 3D endoscopes. But it doesn't mean you can't get depth perception. I think that's where the misnomer is. If you've been watching, obviously, my other channel, the Wax Whisperer, where I'm using the iClearScope, you can see that I've got depth perception with that, and I've acquired it. Probably does take a bit of training, but I'm able to judge the depth because I'm always on the eardrum. If you watch the videos, we're quite comfortably working on the eardrum with that. So I'm using and obtaining depth perception with the endoscope differently. I'm using what we call monocular cues. And they involve, with an endoscope, you've got such a fantastic wide field of view. You can see the entire ear canal, and from that you can look at different landmarks and decipher where you are in the ear. Of course, if an object is further away, it means that you're farther away from it, and if it's closer, it means it's near to you. So moving the endoscope forwards and backwards can help you judge the depth. You use shadows, contours, also something called motion parallex, which is another monocular cue. I've described that quite a lot, but I'll quickly just explain it. If you're on the highway or motorway, the car next to you, if they're speeding past you, they're going to go quicker past you than something in the distance at the end of your eye line. And with an endoscope, as you go forwards and back, the wax that's just near to the tip of the endoscope is going to be moving quicker than, for example, the ear canal wall, which is a bit further away. And we call that motion parallex, and you gain depth perception with that. With the WAXscope, it's mainly focus driven. So you can see I've got this piece of skin deep in the ear in focus, and so I know I've got the depth. So it works differently. So don't let anyone say that you can't get depth perception using monocular cues, because that was a big thing that when we first introduced the endoscope in the UK, obviously there's a lot of status quo, weren't happy, and we went through a bit of a tough time actually. But eventually people saw the benefit, because like the WAXscope, there is no hiding away. We've got videos to document procedures, so no one can, if anyone's, I remember one of the membership bodies, not that membership bodies guys, don't worry, there was another one who were really speaking ill of endoscopic earwax removal, and we challenged them, and in fact they had to then rewrite the whole guidelines and protocols, because obviously the person writing this didn't have the foggiest about an endoscope, never held one before. There was obviously conflict of interest by this individual because they ran their own earwax removal course, and they were using head-worn microscopes, loops we call them. So you just develop it in a different manner. And again, this individual had to redact their original comments, because for every criticism they labelled, I had a video to disprove it. So that's, and again with the WAXscope, so again, there's video documentation of what I'm doing, so we know it works because I'm performing the procedure. So if anyone says it doesn't work, well, it's not the device, it's the person using the device. Similarly with the endoscope, but obviously with the endoscope, I think I'm on 1,500 videos, and I mean, they're just a fraction of the procedures we've performed. There's so many other procedures, I just won't have time to upload each and every single procedure. And with the WAXscope, I think we've racked up about 140, 50, and I've still got tons of videos on my app to download, but it's just getting the time. So moving on to the right side, again, just dilating the ear. This wax isn't as it did. It's still quite, or should I say dead skin. But the surface is quite smooth and hardened, so it's difficult to get suction grip. So there's just now, with this side, I'm able to use the forceps a lot earlier. On the other side, there was nothing to grip onto. I had to move the keratin plug inwards to be able to glide the jaw in between the keratin plug and the canal wall. But here, there is a bit of a section here in the middle. I did use the forceps there, but it's a bit tricky still to get the grip. So I'm using the ear pick. I'm going over, I'm just slowly rolling this out. And again, because it's in focus, we know we can judge the depth. Slowly just bring this forward. So it's just getting trapped near this entrance. This ear was a bit narrower. So again, I'm just stretching the ear, and that's where it's a lot easier to do with the speculi compared to the endoscope. A lot of people struggle stretching the ear with the endoscope. But with the speculi, it's like a funnel, so you can insert it into the... It's still not easy to stretch and dilate, because you've got to be careful you don't make contact with the second bend of the ear canal. So you can go into the ear where it's cartilage, and then you're having to straighten and manipulate the speculum, and it's then quite easy to bump into just past the second bend, which is the bony part. So there is a skill involved there as well. You see it's quite a few hairs, almost like whiskers near the entrance. Oh, it's a sizable plug out. Gonna stretch the ear open. So the occlusion's more or less gone, but there's just a bit of keratin at the bottom. The eardrum's visible there. Just having a nosy around. Again, I'm just stretching the ear open. And again, just there's a comment left by a fellow colleague, and it was more of a point of view they mentioned. It wasn't criticism, but they don't use the endoscope because they said they experience a lag. So the image on view, it's somewhat delayed. It's not real time, which I was quite surprised to hear. And this is where the problem lies. There's a lot of people providing training or equipment who are not really in tune with the training and equipment themselves, and the equipment is not always great. So I questioned why they were getting this lag, because I've never experienced that. And I think I know why. They probably got a very poor quality light source. So the light source is what is, it's like a torch. It's attached to the bottom of the WAXscope, and it acts as a handle. And then we got fiber optical cables running through the WAXscope, like the endoscope, projecting this light, channeling it into the ear. But if your light source is quite of poor quality, then it means the image on screen you're getting is not bright enough. So on the app itself, you can increase the brightness, but by increasing the brightness, the exposure, what you're actually doing is slowing down the shutter speed of the iPhone camera. And when you slow down the shutter speed, because by slowing that down, it allows more light in, so it makes things brighter, but then you also experience a lag. Now, prior to the iPhone, I was using the iPod second generation. I think even before that, it was the second generation and third generation we've used, and I've never ever experienced lag. So, and that just goes to show if the training is not adequate or you haven't got the appropriate equipment, the person can have a negative connotation of the technology they're using. And that's why with the WAXscope and the endoscope, I'm very careful. I want to make sure people fully know how to use it, because then obviously it'll reflect badly on the device, or we know the device is working well because we've got all the documentation to prove that by the means of the videos that I upload. Well, I hope you enjoyed that video, guys. If you are interested in the WAXscope, please do email info@clearwax.co.uk. Take care, bye.